Hello, my name is Jay Byer-Krapensky, and I'm a kidney and liver transplant recipient. I was diagnosed in 2012 and had my transplants in 2013 in January. And I've been doing advocacy work and other things for the American Liver Foundation for about 5 or 6 years at this point, doing some patient education as well as some advocacy work both at the national and the state level. And today we're just going to talk about some questions that we often get about liver disease and from different patients that we've gotten over time. And today we have Dr. Lee with us, and I'll let him introduce himself and his background.
Hi, everybody. Nice to meet you. My name is Dr. Lee. I'm one of the hepatology fellows here at Tufts Medical Center. So basically, my specialty is in the liver, and we do get to see a lot of cirrhosis patients. And Jay, I'm just hearing a story that's phenomenal that you were able to get a dual transplant. And ever since then, you were doing a lot of advocacy work. So I really respect that. We do see dual transplant patients every now and then. It's a very difficult and tough, hospital journey to say the least. But I'm really glad that you're participating in this type of conversation and also this advocacy work. And I just want to give a lot of thanks to American Liver Foundation for this opportunity to be able to answer some of the questions that I think a lot of patients may have in terms of their diagnosis and their cirrhosis progression is definitely one of the things that I often run into actually a lot of times, and not just in the clinical side, but also during the patient encounters. A lot of the patients are obviously and reasonably so afraid of their diagnosis. Hearing the word cirrhosis can really strike a certain degree of fear in their hearts, I think. And I think this opportunity is very well presented in terms of hopefully I'll be able to within my realms of knowledge and whatever I can provide, be able to clarify some of the the questions around it. Okay. Yeah.
Thank you. I think I agree. One of the confusing things for patients is when they do get that diagnosis and they really know nothing about it. I mean, you hear some anecdotal things, whether it's in on TV shows or maybe in the press or in other areas, but you really don't, as a patient, understand what that means, and you get that diagnosis, and it is very frightening. So one of the questions we do get is just to talk about what are the stages and the typical timeline of progression of liver disease? And I know there's probably no typical, but if you can give us just kind of a general background of the stages and the timelines.
Yeah, so I think that's a really good question. And it's a relatively condensed question in the sense that you're exactly right. It's that there's so many environmental and genetic factors. There's so many different multiple factors that play a role in terms of liver disease progression, eventually leading to cirrhosis. But just like all roads lead to Rome kind of thing, basically cirrhosis is sort of the end product, the end result of essentially accumulation of fibrosis. And so what I mean by that is fibrosis, by definition, is basically liver response to liver injury. So what I mean by that is when liver has some kind of liver injury or liver insult to the hepatocytes, which is basically under cellular level, when the liver cells are attacked and damaged, then these other cells called stellate cells actually starts responding to those damages by essentially stimulating fibroblasts and stellate cells to secrete this collagenous product called extracellular matrix. And that by itself is sort of a natural response that liver does in a way, gets triggered by the liver injury. And essentially we call that fibrosis. Liver scarring is basically another more layman terms to describe that. But what happens is the scar sort of takes over, the scar tissue sort of takes over internally, and it really gets interpositioned between the functioning tissues, and it really starts taking over and starts developing to liver cirrhosis. So to answer your question, yeah, so we have, from medical perspective, we have developed several stages to sort of better define this, because ultimately to really know what's going on in your liver, we have to get a liver biopsy. And by using series of liver biopsies through multiple studies, we were able to identify that there is a strikingly similar, matter of fact, identical pattern of how this works. Is that this fibrotic tissue starts depositing in these what we call the parenchymal space, or the functional space of the liver, and that slowly accumulate into more and more fibrosis that essentially take over majority of the functional tissue. And so you're really left with a very small reserve of functional tissue with significant scar tissue. And matter of fact, when you look at these cirrhosis livers, when you look at the outside, even the outside externally, it's overwhelmed by scar tissue. So basically what happens is small bit by small bit, scar tissue starts taking over, and then we call those fibrosis stages. And then, there's up to 4 stages, but it goes from the first stage, which is minimal fibrosis, and then you get more scarring, and then over time eventually becomes cirrhosis. Now, in terms of the timeline and the natural course of disease, it really does vary a lot between patients. Obviously, and also varies a lot between types of liver disease. So try to make this as short as possible for relatively comprehensive question here. But for instance, some examples that come into my mind is, if you have, sort of relatively benign non-alcoholic fatty liver disease, in the sense that, really don't have a lot of scarring, and you don't have a lot of risk factors. You're maybe a pre-diabetic with, high blood pressure, but you don't have the full-blown diabetes or non-insulin dependent. The thing is, the chances are the fat in the liver, which causes the liver injury in the first place, won't be that severe. So the scarring won't be as severe as well. And so maybe your course of disease is going to be much different than somebody who's got autoimmune hepatitis with a rapid flare, or Wilson's disease, or something that's more predisposed to more acute events. So that is like, for instance, if you have if you're a patient with autoimmune hepatitis with a flare, that's a rapid sort of assault, a diffuse assault on the liver, really an acute assault on the liver that really damages a significant component of the liver, and it just really stimulates a sort of a full-blown wound healing response. And what I mean by that is really a lot of scarring and fibrosis turnover. And so then, the patients with those type of liver disease are going to unfortunately have more fast, more rapid development of cirrhosis, and sometimes intermittently these patients can develop liver failure even without cirrhosis. So it really all depends on the type of liver disease, and sort of the amount of the liver insult that these patients receive.
Yeah. And that's one of the things I think we find often that's confusing for patients, because when I talk with our liver support group at the University of Minnesota, for example, they'll say, well, how can this patient be transplanted, for example, so quickly when they really weren't all that sick very long? And I've been waiting 2 or 3 years because my disease progression has been very slow, depending on what their underlying disease is. And I think for just the general patient population, sometimes they can see, well, they don't understand that those different diseases do progress at different rates, even though that scarring and that cirrhosis is basically the same thing happening. It's really the progression and the timeline is affected by that. So it can be really, I know for quite a few patients, just they can kind of just, sometimes it's a downer for them when they see somebody that, kind of gets sick really quick and then is transplanted when they've been struggling for so long. So, and that kind of leads into my next question a little bit. How do the symptoms correlate between the different stages of liver disease?
Yeah, so I think that's a great question, and I have addressed this question actually with multiple patient encounters, and it's actually one of the more common questions I get, is how do I know that I'm really sick, or what kind of symptoms should I expect if I start developing this advanced fibrosis, or really the significant scarring stage, which is irreversible scarring stage, which is basically cirrhosis. And the thing about this, and the truth of the question is that this is why the liver disease is so scary. It's because a lot of times it's actually asymptomatic until it really reaches the late stages of disease. So, matter of fact, a lot of patients, we have one of the leading causes now for cirrhosis, actually now fatty liver disease. It's essentially toppled, hepatitis C and other viral hepatitis. But the thing about this is that non-alcoholic fatty liver disease is very indolent in terms of it's very asymptomatic, and then once it really reaches the cirrhotic stages, that's actually when you start really developing those symptoms, the scary symptoms like the fluid filling up your belly, and what we call variceal bleeding, which is basically bleeding, your esophageal veins basically rupturing and causing bleeding, and all these different types of things happen when you reach the cirrhotic stage. So a lot of times what we get is we get patients who had some kind of unrelated abdominal pain or some kind of reflux type pain, ended up getting an ultrasound for whatever reason it may be, for an unrelated reason. But the ultrasound picked up some fat in the liver, and they ended up coming here. And then when we do FibroScan, which is basically the specialized scan that looks at really the scarring, the amount of it quantifies the amount of scarring and the fat in the liver. That's how we actually pick up cirrhosis in some of these patients who are asymptomatic. So to answer your question, the downside of this is that a lot of these patients even with cirrhosis remain asymptomatic. You can get some mild pain, about a 20% of the patients can get some mild pain from stretching of what we call the liver capsule. That's when you have some kind of, hepatomegaly, some kind of hepatic congestion, and some stretching of the liver capsule because, the liver is enlarged. And that can lead to some mild pains and whatnot. But really the symptoms that, that are, I think, more relatively well known, talking about ascites, which is the fluid, swelling up your belly, and the variceal veins and whatnot, is really the manifestations of late stages of cirrhosis. And so, that being said, there's really no good way to symptomatically know whether you have underlying liver disease or not, and that's why it's so important to, make sure that you go to your routine clinic visit with your PCP, where they're going to do a routine periodic blood test, just as part of your routine assessment and part of the comprehensive metabolic panel. And as part of that, they're going to check your liver function test, and that's why it's so important to get that checked periodically. Yeah.
Well, that brings two things to mind just in my own case, where basically until I became jaundiced, I can't say that I had any really obvious symptoms of liver disease until suddenly I turned orange one Sunday. And, had I been maybe a little bit more aware, maybe I might have felt some abdominal issues or some other things, or maybe hadn't been feeling quite well, but all of a sudden it quickly manifested itself. And so it was kind of a little bit kind of a major wake-up call, obviously, when you turn orange or break this greenish yellow color. It's hard to describe that color, but it was just really kind of shocking. And the other part of that, I think, related to what you were talking about, is just that basic liver, function panel, which I don't think, at least in my former history of going to see my doctor, really was ever really pulled very regularly, which was a little bit kind of concerning to me looking back after the fact. It was like, well, shouldn't everybody have a baseline liver function test to really kind of know every time they go in? So you could maybe hedge some of these things off. So it's just one of those little things that triggered in my head as we talked. Now I know the liver is one of the questions that people are always, or not questions, but things that they're amazed about related to the liver is it can regenerate itself. Can you talk a little bit about the liver's ability to do that? And then how that relates to any damage that it may have, and can it really recover, or when is that tipping point of when it can't?
Yeah, so I think this again, traces back to our first question about liver fibrosis and sort of the physiological elements around that. And I guess, in terms of liver fibrosis, so ultimately really what we really look for when we look through a liver biopsy. So, say that a patient comes in, to the clinic, to the liver center with elevated liver enzymes, and, we sort of do a sort of a blood work and some imaging workup. And then, as an ultimate sort of gold standard test, we get a liver biopsy. And that's so important. It's critical that we do this as part of the diagnostic workup, because what the liver biopsy tells us is really the information about how much scarring and how much functional liver tissue is, and what type of liver damage caused that elevation of the liver enzyme in the first place. So it's really not just diagnostic, but it's also able to quantify the type of damage and the degree of damage. And what happens is that, as I said earlier, is that there's functional hepatocyte, well-functioning, healthy hepatocytes. But when they get damaged, they go through a series of actions called apoptosis, which is basically cellular death. Basically means cellular death. So when they have liver injury, these cells start stimulating internal response systems that eventually become, apoptosis. It eventually starts, disintegrating through apoptosis. And you see that through like all these inflammation around the areas. You see all these infiltrations of these neutrophils and lymphocytes, all these other immune cells that are basically circumventing around the area of liver inflammation. And then around that, you see some scarring that's happening. And so what happens typically is that the scar tissues form around what we call the perivenular and centrilobular areas. So that's around the veins, the portal veins, the central veins that goes around each of the functional cells. And so you get those fibrosis that happens in both the centrilobular, one of the veins, as well as the larger veins of the each functional units, if you will, of the liver. And then these fibrosis starts forming bridges across each other. So you can imagine there's like scar tissue around the veins that happens because, as you can imagine, the veins is where all the inflammation happens, because the inflammatory cells has to circulate from the rest of the circulation, and start infiltrating that area. So it starts off around the veins, and then it starts connecting with each other. We call that bridging fibrosis, which is like the scars basically connecting with each other. Until that point, I would say most of the cells, well, after liver injury, after apoptosis, actually the liver cell still has the ability to regenerate in the sense that there's still enough capacity, the functional cells, to just heal off the scars, and the scar tissue eventually sort of dissolves on its own. And then these the hepatocytes become very functional again around the area. But once you start forming these bridges across the veins, and once you start forming these bridges, once these bridges come together and more collaterals, more collateral bridging process happen throughout the veins, it starts forming something called nodules. We'll call those fibrotic nodules. And that's when you have essentially sort of a significant reduction in the liver ability to basically regenerate, because that area that it takes up is really a lot of scar tissue. And so, by that time, it's really an irreversible process. The scar tissue is unable to sort of be mitigated by other cellular mechanisms. And so that's there permanently. And that's when we call microcirrhosis or micronodular cirrhosis. Although it's not externally completely cirrhotic, when you look at it internally, there's these heavy bridges and fibrotic nodules that have formed across these veins that is now potentially irreversible, and thus indicates relatively severe liver damage. At that point, I would say regeneration is very minimal.
Mm-hmm. Excuse me. So is that, in that case with the nodules, is it the number of nodules then throughout the liver structure overall that determines how cirrhotic that liver is, and whether it could potentially start to regenerate if that underlying health issue is stopped that's causing the liver damage?
Yeah. So once those nodules are formed, at that point, because the connection is already made across, if you will, across the unit of hepatocytes, we call those, the ACE-NAR units, basically the functional unit of the liver. Once you have those fibrotic nodules that basically go across those veins, you're exactly right. Is that at that point the regeneration doesn't happen, because the connection is very strong. The collagenous fibers between the collagenal fibers, but the connection is very strong that there can't be any more liver cells that that can be regenerated through that fibrotic through that fibrotic changes. So it comes down to really the area of effect and the type of morphology that we see in terms of these bridging processes and these fibrotic nodules. When you have like just perivenular, perivenular or periportal fibrosis that is across around the veins, then it's relatively minimal, to the point where I think basically you can get some cellular regeneration around that area. But once you have those nodules and bridge formations, then you're pretty much, wiping off a significant component of, the hepatic space. Yeah.
Understand. So in the case of like somebody whose underlying condition would be from alcohol use, so the damage is coming from alcohol use, they stop, consuming alcohol, using alcohol, however you want to state that, and then, then they haven't gotten to that tipping point. At that point, their liver isn't like 100% functional, but it still can remain functional enough to survive. Is that sensible?
Yeah. So I mean, these when you're in the early cirrhotic stages, basically this is what I tell the patients, that you can really live like a, you still technically still have cirrhosis. That is, there is still irreparable non-regenerative damages that has been done, but you still have a decent amount of functional hepatic parenchyma, because you really have early cirrhosis. And so the risk of developing all these decompensatory events, like whether it's ascites or variceal is relatively low for that patient, as well as the fact that there's still a good chance to really live a normal life with decent life expectancy and whatnot. Now that being said, really the most important step for that patient to take in terms of at that point, when you have a a certain diagnosis of liver cirrhosis, albeit it's early stage, is to basically avoid anything that may potentially cause any more liver damage. So avoiding alcohol, avoiding any kind of medications that may be hepatotoxic, that is may potentially cause liver injury. Really being very vigilant about going to routine appointments. Basically cancer screening then becomes a very big thing at that point, because obviously with those scar changes, what happens with those scar changes is that it actually stimulates these You know, it disrupts really the cytoarchitecture. We call that the cytoarchitecture, which is basically the integrity of the cellular pathways and the cellular, you know, the histology in the liver, the tissue level. Histology in the liver, and then when all those things get disrupted, it actually starts stimulating these proto-oncogenes, that basically cancerous genes, and so you're actually at higher risk because of all these inflammation and scar changes for liver cancer. So you have to be very vigilant about this. So as long as you're vigilant about these type of things and you avoid, you know, all these risk factors and you know, all these risk factors for liver injury, and you're very vigilant about, you know, making those dietary changes and lifestyle, you know, changes, especially for non-alcoholic fatty liver disease patients who've got, you know, obesity and whatnot. You know, you can really prevent yourself from developing these advanced stages and, you know, advanced complications. So it's a really you know, we call this sort of in a way a self-directed, you know, treatment, because, you know, unlike some of the other, you know, diseases that we see where it really just requires urgent treatment or surgical therapies or whatnot, liver is a really sort of a chronic disease in that sense. It really requires a lot of patient effort. Not obviously, you know, providers really need to do a good job in terms of, well, you know, taking care of all these aspects and all these components of liver care. But there's a lot of self-directed care that really comes into play with liver patients.
The reason I asked that question is because I was kind of in that situation where we were kind of at that tipping point. You know, we were doing some steroid treatments to do, you know, to try to, you know, take the pressure off, relieve some things. And then I got to a point where it just, you know, I kind of fell off the cliff. So, and like you're saying, I think we see so many people that if they do make those changes with lifestyle changes, et cetera, and are vigilant, you know, they can hedge off some of those things. And I think that's important for people to understand. And I think the important thing too is to go in and see that doctor and make sure that you're following those things. Because I think sometimes people, when they suddenly get a diagnosis like that, they immediately kind of retreat and they're fearful and they don't follow through with, you know, additional care. And then you do get to that point of being, you know, too cirrhotic and, you know, going down a different path. So one question related to all this is, if somebody is in stage 4 liver disease, how long can they live with it? And I know that's a kind of a tricky, loaded question, at least from my limited experience of being a layperson. But if you could maybe give us some insight on your thoughts there.
Yeah, so I mean, you know, there's a lot of data that's out there. There's a lot of variability on the data, but, you know, again, it really comes down to really the key components of cirrhosis and liver care. So, you know, cirrhosis, it's a really, I think, a very scary word. And you know, it's you know, when we think of cirrhosis, we see those, you know, we think of cirrhotic patients with really the full decompensations and whatnot. But, you know, patients with really early stage cirrhosis can, you know, expect a relatively normal life expectancy, that is, without any significant differences in life expectancy. I mean, there is obviously variability in the data there. There is some, you know, data that suggests that, you know, there's maybe like plus or minus 10-year difference. You know, it really is variable. But really, you know, I've seen, in my experience, I've really seen patients live a relatively long time with cirrhosis, as long as they're very vigilant and very careful about their liver health, and they try to be very proactive about their liver health. You know, that being said, then again, you know, these patients are always very vigilant, and they're very cognizant of the fact that their liver is, you know, to a certain degree, very sensitive. You know, they're sort of living with a very sensitive liver. And so they, you know, absolutely refrain from any alcohol intake. They absolutely refrain from anything that may cause any damage to the liver. And they try to live, you know, as proactive and as active lives as possible in terms of exercise and, you know, weight loss and dietary modifications. And they actually become more healthier after their diagnosis, in the sense that they lose weight and they get rid of their diabetes and their A1C goes down and their metabolic parameters actually improve and so on. So, I mean, if you think about those type of patients, which those are more of the exceptional patients, if you will, the rarity, you know, they're a little bit more rare, but, you know, these patients live for a relatively long time. That being said, there's always that risk of developing decompensation. And once you start developing decompensation, your life expectancy actually significantly decreases. Unfortunately, that's pretty well validated. So I don't want to argue with that. So really the key component here, and you mentioned, you know, patients with early cirrhosis. For patients with early cirrhosis, really the key component is just being very vigilant about your liver health, making all those dietary changes, making all those, lifestyle changes, and going to your routine, you know, liver appointments, making those, make sure you're doing those screening endoscopies every couple of years, and routine, hepatocellular carcinoma or liver cancer screening every couple of months, 6 months usually, and just being very vigilant about that can really certainly help you in terms of your life expectancy and whatnot. Yeah.
And I think that's one of the things, those of us that do advocacy work and education work for American Liver Foundation are trying to do is try to get that word out there and educate more so that people are more aware, one, what their liver does, but two, that if they do develop problems, it's not necessarily it's not going to be, I don't want to say a death sentence per se, but it's not going, you can, mitigate some of the factors that are going on as long as you're vigilant and do the right things. And hopefully we can also avoid people getting into that situation to begin with. Now, granted, there's those genetic diseases and other things that are unavoidable, but those ones that are avoidable, the more education people can have about your liver, because quite frankly, I never really thought about it. I knew what it was, I knew what it did kind of, but I never gave it a second thought until I had problems. So. And I know one of the problems that I had that was really significant through my whole journey was really low platelets. Can you describe why patients with cirrhosis have low platelets, and then how that can affect the spleen and how the interaction between the spleen and the liver take place?
Yeah, so Jay, just to comment on your your personal experience. Actually, it's very common for a patient with cirrhosis to develop low platelets that actually can become a very sort of a chronic lingering issue. And can become a big issue, obviously, for the patient and obviously for the provider as well, just because low platelets, thrombocytopenia, we call it thrombocytopenia is the medical term for it, but that can lead to increased bleeding events, whether it's through GI bleeding or some kind of other bleeding, significant bruises, hematoma formations. These patients, we really recommend against surgery, not only because of the cirrhosis-related risk, but these patients often develop all these bleeding complications following surgery because of the low platelets. So there's multiple issues around that really makes it into a sort of a big problem. So I'm really glad that you actually asked this question, and I hope that I can answer this on behalf of many patients who are struggling with this. Is that unfortunately what happens in the setting of cirrhosis is that you get something called portal hypertension. So this to speak more microscopically and really just to go back into the sort of dive back into the the sort of the pathophysiology behind this, is that when in cirrhosis, I talked earlier that you get these scar tissue formation, right? These scar tissue basically really distort the integrity of the tissue around the veins that goes through we call those portal veins, the big veins that goes through the liver. And what it does is that because of these scar tissues and significant distortions, it actually compresses, if you will, on the portal veins that's going through these functional units of the liver. And so collectively, what that does is that escalates what we call the intrahepatic portal pressure, or the portal pressure, or the pressure through the venous veins that's going across the liver. And then that collectively, that's called portal hypertension. And what happens is that portal hypertension, the portal vein is connected to the spleen. Actually, what happens is that the blood from the spleen goes up through the liver, and it goes up through the IVC, or the inferior vena cava, and goes to the right chamber of the heart, and then it circulates around the systemic circulation. So you can imagine, if the pressure builds up in the portal vein with portal hypertension, then the pressure is going to be transmitted across the splenic vein that feeds from the spleen, and then spleen is going to be congested. One of the things that spleen does, the problem with this is that one of the things spleen does is actually is a filtering organ. So what it does is it filters out diseased cells, and functionally, and in a normal spleen, it's supposed to get rid of all these diseased and dying cells that's sort of torn, that's sort of torn from some kind of circulatory circulation and whatnot. So it's supposed to clean up the cells, if you will. And so what happens is that because you get this backflow of this portal vein into the spleen, and the spleen gets congested, all these cells that really shouldn't be filtered out gets filtered out. And so really, the most significantly, the platelets starts to get filtered out by the spleen. We call that hypersplenism and splenic turnover. And so what we get is all these platelets that get filtered out by the spleen, and then you get basically thrombocytopenia from this hypersplenism or high platelet turnover. On top of that, especially for patients who drink alcohol, alcohol-induced liver cirrhosis, alcoholic cirrhosis, these patients also suffer what we call marrow suppression. So that's the alcohol directly affects the bone marrow, if you will, and it actually suppresses. Bone marrow is where all the cells get all the cells starts, all the cells starts differentiating into, the actual, white blood cells or red blood cells or platelets or whatnot. So what it does is the alcohol, affects the bone marrow and causes, suppression of that development. And so actually, that's another factor that contributes to thrombocytopenia or low platelets in these patients. And so there's multiple mechanisms involved. The primary mechanism is through the portal vein and causing, hypersplenism or splenic congestion that then turns over to platelets and then leads to thrombocytopenia.
Yeah, it's something that I just run into so often, and everybody has that question, and it's like, well, that's a little hard to explain if you're not a medical person, not a doctor. Although all we can say is it does happen, and it's fairly common, and sometimes I think it just shocks people. Why would I have low platelets? But the whole backing up and not being able to filter those bad cells makes a whole lot of sense to me. One kind of question related to portal hypertension, I guess, in some regards, is also the effect that cirrhosis and liver disease would have on kidneys. And I guess that's a little bit like really close to home for me, having a liver and a kidney transplant, because I had hepatorenal syndrome 1. And when I initially got really sick and was hospitalized and was in intensive care for 49 days, and I won't go into my whole saga that way, but it was a touch and go experience. And, at the beginning of that whole ICU journey, my kidneys had obviously failed when I had gotten already to the hospital, but they thought if they could reduce pressure and other things that maybe my kidneys would start to come back. Unfortunately, that didn't happen in my case. But if you could talk a little bit about that interaction between the liver and the kidneys, and why some of us do end up with dual transplants due to that.
Yeah, so actually that's one of my, one of my favorite topics actually is the liver and kidneys, and it's actually unfortunately one of the most dire prognosis that you see in liver patients and cirrhotic patients. Unfortunately, with cirrhosis, you sort of start off with varices. You start developing varices, esophageal engorgement of the veins, and then after that you start developing. Sometimes you can get obviously from these patients you get the variceal rupture. When I'm talking about the stages, the natural progression of cirrhosis, that is, I'm talking about the late phase, not the early phase, really, but really the late phase. And then you start developing ascites, which is basically the fluid filling up your belly because of portal hypertension. And then when you go even beyond that, at that point your prognosis is really sort of cut. Your chances of survival starts really slow, going down a little bit, quite significantly actually by that time. But when you develop the kidney issue, when you start developing kidney damage because of cirrhosis, we call that, as you mentioned, hepatorenal syndrome, you really start, at that point you're really at a sort of a very difficult diagnosis, very guarded diagnosis, guarded prognosis, if you will. And the reason why is because the kidney is sort of the last reserve in terms of what we call the portal systemic circulation. So to put this in as in sort of layman terms here is that your kidneys are very intimately connected to the circulation around the liver. And so basically what happens is that in the setting of really end-stage cirrhosis with elevated portal pressures, you get something called bowel translocation, bacterial translocation, or bowel bacterial translocation. So that's basically what happens is, because of that elevated pressure, the veins beneath it, we call those splanchnic veins. We call those splanchnic veins, just a medical term for it. There's a natural response from these veins to start dilating, because what they want to do is they want to be able to increase the perfusion pressure, right? Because there's elevated pressure, so the forward flow is relatively limited. So they do that by causing splanchnic vasodilation, and from that it actually forms collaterals. It forms other veins around the liver and the intestines. The problem with that is that when you start doing that, all these bacteria that's living in the intestines, and as well as all these substances and all these substrates that are secreted by these bacteria that normally live in the intestines, gets circulated around throughout the system. And so what a part of that substrate, we call it nitric oxide, is secreted by bacteria. And what it does is it actually really affects the vessels around the arteries. It really affects the arterial circulation and causes vasodilation. So that's dilation of the arteries in the systemic circulation, in the non-portal systemic circulation. And what happens with that is that I'm really sort of going into really sort of complicated physiology, and actually this is even difficult for some physicians too, just FYI. But what happens in that setting is that, you know, there's dilation of the arterial circulation, including the circulation that is connected to the kidneys. And so your kidney senses that and it starts secreting all these what we call hormones. Really, it's hormone called it renin-angiotensin system. So those are, you know, vasopressins and, you know, angiotensins and all these other, you know, sympathetic, you know, nervous system and all these other very vasoactive hormones. So those are the ones that really causes vasoconstriction or constriction of the arteries and the arterioles. And you get over secretion of this because your kidney thinks that there's lack of volume, when it is really just significant dilation of the arteries is causing reduced volume, essentially reduced circulatory volume. There's a lot of physics involved with this as well. But anyways, so you get over secretion of all these hormones that basically affect the renal arteriole, which is basically the renal arteries, if you will, or part of the renal artery, and it causes renal vasoconstriction. So it's almost selectively and more differentially affects the renal perfusion arteries and causes vasoconstriction, which is constriction of the vessel that's feeding into the kidneys. So you can imagine that if that happens, once that happens, the circulations are supposed to keep the kidneys alive, is sort of cut off, if you will. It really goes down significantly. So then the kidneys then become injured by this process. And so you can imagine all these significant hemodynamic changes, as a circulatory changes, really culminate to this end result, which is significant kidney injury. Once you get to that point, basically what that's telling you, what that's telling you in terms of provider standpoint, or what that patient's body is telling you, is that, look, you know, the body's basically screaming, you know, we're really in the end stages here in terms of, you know, cirrhosis is really bad. There's significant portal hypertension. You know, from the body's perspective, I'm trying to do my best here to, you know, perfuse the kidneys by secreting all these hormones, but, you know, ironically, it's actually causing more kidney damage. And then it becomes a sort of a vicious cycle where there's more portal hypertension, more systemic vasodilation, more neurohormonal secretion and vasoactive hormone secretion, and then more vasoconstriction of the renal arterioles, and then your kidneys just continues to get damaged. And so it becomes a really tricky situation, and really a treatment for that, to, you know, just to maybe go a little farther into the question here, is that really a treatment for that at that point is, you know, if you're developing any like pressure issues because there's such a significant vasodilation, then we often put you on pressors, and that's usually, you know, in the ICU. And this pressors is just artificial medications to keep your blood pressure, you know, to cause that vasoactive mechanism to keep your blood pressure at a perfusing pressure. The other things we do is something called octreotide and midodrine, which are also sort of vasopressor type medications, not as invasive or not as strong as vasopressors, but it also works on the splenic, you know, the veins that I mentioned earlier, the splenic veins, which is below the liver, to basically cause, you know, vasoconstriction, you know, be able to perfuse the rest of the circulation. So there's a lot of medications involved in these settings to keep the pressure above a certain pressure, perfusing pressure. To be able to really perfuse the kidneys to prevent you from going into essentially, you know, full-blown liver failure and renal failure. At that point, when you get to that stage, you know, unfortunately, your prognosis is very, very guarded. Talking like, you know, a couple of days to maybe a week,
Yep.
you know, type of thing. And so that's something that we really don't like to see. That's something that we really become very vigilant about that. As soon as we see that, we have to get, you know, renal team involved. It's very a multidisciplinary effort. It's ICU, renal, you know, liver hepatology. It's, you know, very multidisciplinary team. There's a lot of things that needs to play during that time. And so it's a very, you know, difficult diagnosis, to say the least. Yeah.
Well, and it's definitely you don't want to get to that point, and just my personal experience was not pleasant. And even though I don't remember most of it because I was in an induced coma for all that time, but it definitely was not what you want to go through. And I think at one point in time, my wife counted like 17 doctors at least, and like probably 7 specialties that were coming in trying to deal with it, just because there's just so many things, like you're saying, going on at the same time. And when, you know, the body's doing something to itself that is causing the problem, that even makes it more challenging. So, and obviously that's the extreme, but we also do see, I think, just the average liver patient that I run into that does have higher creatinine scores. Is that just part of that whole process where they're not at the really severe end of the spectrum we were just talking about, but just the beginning stages when it just is starting to affect that kidney just a little bit?
Yeah, so the caveat to that is that hepatorenal syndrome, you mentioned the two types, but really just hepatorenal syndrome in general. Really, the caveat to that is that what you're going to see is a sort of somebody who's basically jumping from relatively normal kidney function to a rapid escalation of creatinine to so basically full-blown renal failure or kidney failure. So there is definitely a very strong escalation in hepatorenal syndrome. There's other patients, other cohorts of patients or other phenotypes who already have underlying kidney disease, chronic kidney disease, who unfortunately because of that they're actually more predisposed to developing hepatorenal syndrome. But that being said, if their kidney disease, if they already had a chronic kidney disease and their creatinine always was a little bit elevated, then it's sort of a judgment call, but it's unlikely that the patient has developed hepatorenal syndrome. Usually, when you say when you think this patient has hepatorenal syndrome, which is really the scary diagnosis, the patients usually have already pre-existing ascites and other decompensatory events, whether it's variceal bleeding, usually ascites, but hepatic encephalopathy, basically these patients are a lot of times, confused and stuff like that. And so there's a natural progression that leads to HRS, hepatorenal syndrome. But patients with pre-existing kidney disease obviously are at more risk. And the other caveat to that is that the MELD score, which is the score that we use for so many different things. I mean, it's the model for end stage liver disease. That's basically the score that we use for transplant, and the UNOS database uses that. Basically the official transplant organ procurement organization uses that to basically score patients. But that's comprised of bilirubin and basically creatinine, bilirubin and INR, but also creatinine. So creatinine is a big component. Renal function is a big component of this score. So just keep that in mind in terms of calculating your own prognosis.
Yeah. Well, it's just side note real quickly, but when I walked into the hospital when I was first sent to ICU right away, I had MELD score stops at 40, but you can calculate it higher because calculations work that way. A 42, so that's how bad off I was. So yeah.
Wow, that's really high. Yeah.
Yeah. Fortunate to be here. Very fortunate. One of the things that you mentioned is some of those things, those precursors like ascites, varices, HE or hepatic encephalopathy, which I can say today, which not every day can I say that word. We have tests on that at our liver support group to see who can say encephalopathy correctly or at all, because it is a tough word. But I know, ascites, the buildup of fluid in your abdomen. I know when I came into the hospital, I had 18 liters of fluid removed. So I must have looked like I was pregnant, although because I had been, I had HE or hepatic encephalopathy prior to coming to the hospital, and nobody really knew that I did because I hid it pretty well. I probably should have noticed that I had that much ascites, but I never did have any varices. But can you talk a little bit about how those three things kind of play in relation to liver disease and how that changes maybe as your liver disease advances?
Yeah, so I think I mentioned that earlier in one of the questions, but I think it's just such an important point that in terms of natural history of liver cirrhosis, I think it's definitely worth explaining a little more farther in terms of natural history. So when you have early stage cirrhosis, a lot of times you have compensated cirrhosis. That means you don't really have any other complications, and really the big complication, you mentioned most of them, but really a big complication we look at is ascites, which is fluid swelling in the belly, and then when you have ascites, you're at risk for something called spontaneous bacterial peritonitis, which is basically infection of that acidic fluid. It's one of the complications we think of. And then hepatic encephalopathy, you mentioned that it's basically the ammonia, the buildup of toxic metabolites from the liver that's not being properly metabolized, that basically passes the brain, the brain barrier, and it just goes into the the cerebral space to cause confusion, basically toxic effects. And the other component to that is obviously varices and variceal bleeding. And then the lastly is I already mentioned that hepatorenal syndrome. All these components are concerning features of decompensation in cirrhosis. And so early stages, you most likely don't have any of the features, but as you proceed, I mean, one of the, of the complications, I mean, everybody's different. Not everybody develops all 5 complications. God forbid you develop all 5 complications. Usually it's 1 or 2 complications that's already, big enough. But when you go to the next stage, the first thing that a lot of times you develop is portal hypertension is the first thing that you develop, right? Because that's basically the escalation of the pressures in the intrahepatic vein that collectively results in elevation of the portal vein pressure. So when you have portal hypertension, then you start developing all these other features. Because when you have compensated cirrhosis without portal hypertension, that is, you don't have elevated portal pressures, then you're not at risk for developing any of these complications. Because these complications by physiology needs portal hypertension to be developed. So when you have portal hypertension, you're going to develop varices. That's the first thing you're going to develop, and that's because when you have escalated portal pressure, it gets the same thing, same concept with hepatorenal syndrome in a way, with thrombocytopenia and splenic vein and backflow of portal pressures. Sort of the same concept, because what happens is that your gastric and esophageal veins feed into the portal vein. So it goes to the portal vein, then to the IVC again, it goes to the right chamber of the heart and the rest of the circulation. So when you have portal hypertension, there's backflow, congestion of the esophageal veins and the gastric veins, that then eventually becomes gastro and esophageal varices. And so when they really build up to a certain degree and they rupture, then that's when you get significant bleeding, and that's emergency. That's life-threatening emergency. So you want to be in the hospital before then. In fact, even before then, you want to make sure you're keeping up with your surveillance in terms of your endoscopy surveillance. The after varices, you get the development of ascites, which is the fluid buildup in the. Typically, that's how the development works. The natural history works. You get the fluid developing in your acidic space, which is the space between your intestinal organs, your visceral organ. We call those visceral organs, and your peritoneum. So that's between the wall of your stomach and the wall of your intestines. So you get a fluid buildup between that space. And the reason for that is because there's multiple reasons, but to really just keep it briefly is, again, because of portal hypertension. And there's basically extravasation, or the seeping of fluid from the portal space and the liver into the acidic space. There's other more microscopic mechanisms as well, but I'm not going to get into that, obviously. And then the next step after that is, you start developing, what we call, there's some heart changes that happen. Now there's a term for it called cirrhotic cardiomyopathy, but again, I'm not going to really get into that. But then you also get the the final stages, which is the hepatorenal syndrome. And then anytime between that, you can really develop hepatic encephalopathy. Hepatic encephalopathy is sort of a mechanism of its own in a way, because it really comes down to your liver not really being able to properly function in terms of doing all its metabolic functions. And so you can get all these buildup of toxic metabolites that basically passes through your brain barrier, blood-brain barrier, and then really affect your cognitive functions and whatnot. So we can see hepatic encephalopathy with even just relatively mild stages, all the way down to fulminant liver failure or acute on chronic liver failure type picture. Yeah.
It is interesting that the difference of people that develop HE and that don't, and then the severity. Like you say, I've seen some people that I've been around with or know because of the work that I do now, that really early on, like you're saying, had lots of problems, but never really got all that sick or as it didn't develop as badly. And then some people that were really, really sick that really never had any. As far as their cirrhosis goes. So it's interesting how it affects different people in different ways. And then, my fellow liver patients for listening to this, they hear that awful word lactulose, which everybody just runs out of the room screaming when they hear. But, there are interesting ways of managing it, but we won't get into those details today. But it is interesting, when you end up having, a paracentesis, or the draining of that ascites fluid twice a week, it's a relief because it builds up so much pressure on your internal organs and you can't breathe and you have all these other issues. But it's also not the most joyous thing to go through and see bottles filled up, and you can think, are we going to get 6 today, 8 today, 10 today, liters, depending on what's going on. So it is interesting how the body works and how all these things differ in different patients. One question that we do, get is, somebody does have cirrhosis. What can they do to keep it from worsening? And I know we touched on that a little bit, but I think that's also leads into another question is the testing for liver disease? And you kind of talked about that a little bit, but if we could kind of maybe tie those two together here as we get to the end of our talk, so people kind of have an idea of maybe what they could do and what those tests are that are best for determining.
Yeah, so I think those are two probably most important questions of the talk today. I mean, I'm sure a lot of patients are curious about that. And then, so most importantly, I did mention this, as you said, I did mention this earlier, but really, it depends on, number one, when you have suspicion of underlying liver disease, whether it's cirrhosis or non-cirrhosis, you should really talk to your primary care physicians or any specialty physicians you might have, and just say that, hey, look, listen, I'm concerned about my liver condition, and if they're not doing LFTs, just ask them, hey, can I do an LFT, liver function test, to see where my liver is? I mean, if you have underlying risk factors, whether it's diabetes, obesity, metabolic risk factors, hypertension, high blood pressure, metabolic syndrome, whatnot, there's certainly a risk of, developing non-alcoholic fatty liver disease, and you don't really need to wait until, you get it is incidentally picked up. So, I mean, you can always ask your primary physician during your routine checkup, hey, can I just get a liver function test as well as the rest of my electrolytes and whatnot? And so, first things first is that we have to, obviously determine whether you have cirrhosis or not. So when you picking a random scenario here is that if you have elevated LFTs and you come to and then your primary care doctor refers you to a GI specialist or a liver specialist, what we're going to do is we're going to do a plethora of blood work and imaging tests, and nowadays we have kind of moved away from liver biopsy unless necessary. A lot of times we can stick with what we call a fiber scan, which is like more of a specialized scan that looks at that's able to quantify the amount of fat and scarring in the liver. Now that being said, if you have persistent elevated LFTs, and we will have to probably do a liver biopsy and whatnot, or if you can't determine the diagnosis. So we do that, and then once we establish that you have cirrhosis, then we have to determine what caused your cirrhosis. So whether you have significant alcohol history, or whether you have some significant metabolic risk factors, whether you have underlying autoimmune liver disease, whatnot, we're going to do our best to identify that using blood tests and whatnot. And if it comes down to, we might do a liver biopsy, but most likely not in that case. So once we do that and establish your diagnosis, we're also going to do a comprehensive evaluation to see if you have any of the physical examination findings of these decompensations I mentioned earlier. That is, we're going to do a full abdominal exam, a thorough abdominal exam to see if you have ascites, check your knees and your legs to make sure, check your shins to make sure that there's some fluid buildup, make sure that you're cognitively okay, you're able to answer all the questions. You don't have what we call asterixis, which is, just to show you, demonstrate this, when you go like this and you have flapping of hands, exactly, you go like that, yeah. So that's a demonstration, that's an indication that you have, essentially hepatic encephalopathy. You may have something called a covert hepatic encephalopathy, which is different than overt hepatic encephalopathy, which is more, related to your cognitive dysfunction than actual full-blown confusion. So those are all these things that we're going to test. We're going to do a comprehensive exam to look at that. And then once we do that, we're going to do, check your liver function test and all these things that we talked about in terms of your MELD score. So we're going to look at your kidney function, your liver function, your INR, which is basically an indication of your coagulation, right? Because liver affects your coagulation, clotting factors as well. And then obviously your platelets and white count and your blood count, all that stuff. We're going to do a comprehensive assessment. So it's kind of funny because compared to other organs, liver affects so many different organs. And I called it really the heart beneath the diaphragm. What people need to recognize, the liver affects so many different organs that it's funny that we actually do probably one of the more comprehensive liver test, more comprehensive, blood test than any other specialty. So we have to get a full set of electrolytes, kidney function, liver test, INR, complete blood count, all these things. And so once we do that and assess that, determine that you have a compensated early cirrhosis, then what we're going to do is we're going to do some additional liver imaging. And that ties down to the fact that your cirrhosis increases a risk of liver cancer. So we want to do some kind of baseline imaging. Usually it's an ultrasound, unless there's some suspicion that you might have liver cancer, in which case we might do something called a multi-phasic CT or an MRI. which is more advanced testing. And then we'll probably schedule you for an endoscopy. So to take a look at your varices to make sure that you don't have any, high-risk varices that need intervention. And then once we do that and see that you're completely compensated, there's no issues, you don't have any varices, your liver function test is completely normal, everything is normal, then we'll probably schedule you for a routine visit in 6 months with repeat blood work and ultrasound. So that's typically the course. And then endoscopy usually happens every, 2 to 3 years, depending on the, if it's high risk, then you can do it even annually. But even a couple of months actually, if you do some banding and some other additional interventions. But that's usually typically the course. But if you do have decompensation, things may change. Like if you have, let's say, severe, ascites and your nutritional issues, then we might have to do a multidisciplinary approach with nutritionist consultation, as well as, interventional radiology, doing the paracentesis every week to a couple of weeks. Definitely starting you on diuretic therapy, which is like the Lasix and the spironolactone combination to help you get rid of the excess fluid. We might have to, provide you whatever medication you need for decompensation. But if you have any sorts of decompensation, the chances are we're going to see you every couple of weeks just to help you go through that sort of liver failure phase, if you will, or decompensation phase. So that's sort of the gist of the workup and the treatment we provide. And so, I think most important takeaway from this is that if you're concerned about your liver health, then you should ask your PCP about it, especially if you have underlying risk factors, to at least get a liver function test. And if there is any issues with your liver function test, then you should be referred to a liver specialist. If you have cirrhosis or some question, you should be referred to a liver specialist who can then provide you with the right guideline-based, evidence-based medications and treatment to help you through that process. I think that's really the most important takeaway from this, seminar.
Yep, I would agree 100% because I run into so many people who unfortunately happen to live in very rural areas, maybe don't see a doctor very often, maybe have limited access to medical care and advance to a point where they're almost beyond that beginning stage of the treatment. And the sooner that they can get involved with a liver specialist and be monitored, follow that right course of action to remain as healthy as possible, depending on how the disease process plays out, they have a much better outcome than those that come in at a very late stage, because there's very kind of little you can do at that point in time other than kind of manage where they're at, and then ultimately, unfortunately, they're on a transplant path at that point already. So those are great things, and the biggest thing I think too is for the patient to be honest with their provider. I worked with a lot of different patients since my journey. I guess I still am on my journey, but just talking about that, you need to be honest with your provider. You need to tell them all the things that are happening, all the things that you may be slightly ashamed to tell them, whether it's alcohol use or something else, and be very upfront, because if you don't tell them, they can't help you. I mean, you can do all the diagnostic work in the world you want, but unless you know some of those other things that maybe the patient isn't telling you, it makes your job much harder, and makes the treatment just that much more difficult. So from a patient perspective, it's just, we need to be honest with our providers to help you out, because obviously you're trying to do your best for us, but if we don't give you the full information or picture of where we're at, it hinders your ability to help us. So, and that's really where I really like your point of making sure you ask for that liver function test. I kind of, that's my little preaching point all the time to different people I talk to, because so often it doesn't happen. And there's so many things, especially when you're saying like now with fatty liver being such a big issue, getting that checked early and getting on a course of being able to treat that sooner than later is really important. And so I really appreciate all your great information today. It's been very beneficial for me. I've learned a few things about HE or not HE, but hepatic renal syndrome, that a few of those tweaks I didn't know, so I add those to my memory bank. And as we get to the end here, I just want to thank Dr. Lee again for his time, and for ALF for allowing us to put this together. And also check out the ALF website because there's a lot of good additional information, and just be honest with your doctor and make sure you're telling them what's going on, and get that liver test. So thanks again, Dr. Lee. We really appreciate your time.
Absolutely. Thank you for having me here. Thank you.